Yes, hello. You are welcome back again to our channel, our educative channel here at Medical Imaging Consultants, where we are able to offer full range of radiology services. Again, like I said, ranging from CT scan, MRI, X-rays, spatial radiographic technique, and all full range ultrasound, echocardiography, small parts, and everything. So here at MIC, we are able to offer these services, and we are located behind the Wandegeya Police on Africourts building. Contact us for any of these radiology services. However, now I'm going to Dr. James Senoga, is still my name. Yes, my name. And I started this series of helping our radiographers and radio imaging technologists come up with an easier way of reading radiographs. As one will agree with me, a chest radiograph is one of the commonest radiographs one does, and it is only imperative that, it's only logical that we enable the junior staff being able to make sense out of whatever they are seeing before the radiologists come. Of course, this does not replace the radiologist, but I'm thinking about that doctor who needs a quick tip on what to do with the radiograph before the radiologists come in. In some of our centers, especially in our third world countries, we don't have radiologists all over the place, and of course, sometimes the medical officers may require radiology imaging technologists, the radiographers, to comment on the image. And that's where I come in. I give you a brief review how to easily know about these radiographs. I started earlier on by saying that you could make a quick report by systematically analyzing the different aspects of the chest, the wall, the pleura, the hemidiaphragm, and the mediastinum. And of course, now we've looked at the lungs, and the lungs, we look at the bronchopascular markings, where we saw that the alveolar and the interstitial infiltrates are found. Next, let's look at the pulmonary vessels. And again, here we are looking for conditions like pulmonary diseases. Like, for example, in that image there, it is important here to appreciate the normal. Okay, we want to appreciate the normal, such that when we see the abnormal, we can quickly see it. For example, when we're talking about pulmonary hypertension, we are saying the arteries are prominent. Look at those ones, they stand out quite prominently, and of course they cut off immediately. This is what we see in pulmonary hypertension. Then in pulmonary embolus, of course, we want to see the pulmonary edema, which we've already discussed, and they can present with capitalization of the pulmonary vessels, and of course we also saw the edema. Okay, so it is very important that one sees. Now, this image here shows us with a fairly normal cardiac chest vessels compared to which ones are prominent. On the other hand, we may get where we have reduction in the general lung markings, or where we see bullies, and of course pulmonary hypertension. Let's look at some examples here. If we start with pulmonary hypertension, there are so many causes of pulmonary hypertension, but most of they all appear commonly on a radiograph. And the basic finding here is the prominence of the centrally located pulmonary vessels, which cut off. There is immediate cut off, as you can see in that image, okay, which is called pruning. Okay, pruning. Once you see something like this, then you are suspecting pulmonary hypertension. Prominence of the central vessels, which truncate or cut off immediately. Look at, for example, in this image, again you describe the bilateral prominence of the pulmonary arteries, and they cut off. So this is suggestive of pulmonary hypertension. But on the lower side, again, we talk about the pulmonary venous hypertension, that is the pulmonary embolus, which can start with just the catheterization. We get the catheterization, they carry B, they carry A lines, and as time goes on, then we get the alveolar type of infiltration, where we get the central alveolar infiltrates, mainly pericardial, sparing the apices and the bases, and this is due to pulmonary vein hypertension or pulmonary embolus, just pulmonary edema, just like we stated it. So those are some of the vessels, but like I said, on the other hand, one can look at the chest, where we have reduction in the lung markings, paucity of the lung markings. And this can happen in several conditions. One of them is a pneumothorax, okay, when you don't see the lung markings. Like for example, in this instance, you look at the chest radiograph, the lung markings are there on the right, but you don't see them on the left. Could it be due to pneumothorax? Pneumothorax is when we have air in the pleura and it forces the lung to collapse on the high lung. Then the other aspect of the paucity, if it is bilateral and symmetrical, be wary of the factors. If one uses very high factors, there is tendency to burn out the lung markings. Okay, so you get the paucity of lung markings. But conditions like emphysema, where we have flattening of the hemidiaphragm, may also be the case. And of course, here we have the bullae formation. This is the bullae. These are just cystic areas within the lungs. So all these cause the reduction in the lung markings. So if you get this radiograph and you're not able to see the lung markings, what is happening? Look at your factors. Is it overexposed? If it's overexposed, you may not see the lung markings. But if it is not overexposed, then it has flattening of the hemidiaphragm, then probably you're dealing with emphysema. If it is loculated, then probably you're dealing with the bullae formation. But other conditions like pneumothorax can be a differential diagnosis. We've already talked about some of these, especially hydropneumothorax, pneumothorax, where the lung has collapsed, and what you see, there are no lung markings. Bullae formation, best shown on CT scan, can also cause these paucities. The complicated ones may have some fluid and may be multi-loculated. Here, a CT scan is very important. So that is the possibility when you don't see the lung markings. The collapses is one other aspect which we are faced with whenever we are trying to interpret. And when the lung collapses, it may show some signs and symptoms of this. We need to recognize them and differentiate them from a consolidation. Before you do that, again, it's good to review the anatomy, and of course the upper lobe, the middle lobe, and the lower lobe, so that when they collapse, you know where they have collapsed. Usually when the lung collapses, we have obviously reduction in the lung volume, deviation of the adjacent structures, let's say the mediastinum and the hemidiaphragm and the fissure, so it tends to track these towards itself. Again, naturally, that is the negative mass effect. And of course, the lung also increases in density, and we have the prominence of the bronchopascular marking. So when you have these, then you must think about a lung collapse. A lung collapse may be, again, involving one lobe, like for example, on the right, if it is a right lobar collapse, you may get a triangular shaped opacity like that. And here we see it's associated with the loss of volume. Of course, it could be a consolidation, but it's associated with loss of volume, and the trachea is deviated to the ipsilateral side. Once you see that, then you conclude that this is a right upper lobe collapse. Right middle lobe collapse, best seen on a lateral view. Again, an opacity in the mid zone, but the lower zone is what appears like that, because you remember the lower zone is mainly peripherally and in the middle like that. So we should be on the lookout with lobar collapse, because this is what may mimic other pathologies like the consolidations. Whereas if a whole lung has collapsed, it becomes much easier. It becomes opaque. The air, it's devoid of the air, and then of course we see the trachea deviated to that side. Then we say this is a lung collapse. Look at that, homogeneous opacification on the one side and the chest collapse on the other. So these are some of them. On the left, we have two lobes. Again, the right upper lobe collapses with the veil sign. That's called the veil sign, reduction in volume, and then of course we have the trachea deviated to that side. The segmentals best seen on the CT scan, and of course the left lower lobe collapses with a triangular shape just below the cardiac shadow. So, in a nutshell, this is when we have lung collapse, and the lung collapse may be segmental. On the right, if it is segmental, and we say if the lung is collapsed, there is reduction in volume, there is deviation of the mediastinal structures, there is increase in density and prominence of the bronchoplasma. Once you have these, then you have a collapse. And of course, on the right, we have 3, upper, mid, and lower, and of course, on the left, we have 2, that is the upper and the lower. And these can be demonstrated easily. Yes, a quick report on one of these could say there is loss of volume, predominantly involved the left upper, with increased density and prominent bronchofascicular markings. There is associated mass effect and traction of the mediastinum to the ipsilateral side. No other pathology. Then you conclude features of left upper lobe collapse. So that could be would constitute your report. On the other hand, one may think about the opacification. We've looked at opacification of the hemidiaphragm, and you have seen that an opacification of the hemidiaphragm could be caused by collapse of the lung. But there are many causes of a homogeneously opacified hemithorax, just like you see one here in the image. The guideline on what is causing it would be the effect it has on the mediastinum. For example, if it is tracking the mediastinum, you can see the trachea there is being pulled to its side, then we know the cause of this is lung collapse, that's reduction in volume. Whereas on the other side, if it is pushed, if the mediastinal structures are displaced to the contralateral side, then we know that this opacification may either be massive pleural effusion or a mass, a lung mass compressing on the cardiac shadow and displacing it to the contralateral side. If there is no significant impression on the mediastinum and we have a homogeneous, then we think about the viral effusion and pleural effusion. Okay, the examples down here again show that yes, the homogeneous opacification with the traction of the trachea may mean the lung is collapsed. You can also see the crowding of those ribs. Then if there is an air-free level, like we see in this image, then we can also say this is hydropneumothorax. Yes. Some conditions like the pneumonias, especially the viral pneumonias, may cause bilateral opacification. And of course here we can see that both the hemithorax are opaque, but here we see that they are more opaque in the lower zones, and then there's no significant mediastinal shift. And then you can say if it is bilateral, most of the time it is caused by the viral pneumonias. The approach to writing then comes in again as we conclude that usually the eye sees what it knows. So as we went through the whole system, we started from the chest wall to the pleura, we went to the hemidiaphragm, then to the cardiac shadow, and then to the lungs. So some of these conditions which we have seen help us to know if we have seen it before. Like for example, the collapses. We have seen it before. Then in our mind, we say this is this. So we already conclude about the differential diagnosis. Now, when we come to write the report, we say that we mention the positives that are there for that condition and the negatives, okay, to rule out the differentials. And of course, then, of course, if you are not sure of the differentials, then you are able to describe what you see and you leave it there. And whoever reads your report may be able to work out. For example, in this image up here, you look at it quickly and you say, this is most likely an effusion. Why is it an effusion? Because we don't have any loss in volume and we don't have compression on the mediastinal structures. So then we say it's an effusion. So then we write a report knowing this is an effusion. Okay, then we say there is a generalized homogeneous opacification over the right hemithorax with a positive silhouette sign, hemidiaphragm and mediastinum, and with significance there is no compression of the midline structures. That means we rule out a tumor or massive effusion. Okay, and of course we also say there is no air bronchogram, rules out a consolidation. These are the negatives. Then we conclude that the above features are most likely due to pleural effusion. Okay. On the other hand, if it is that image, after you looked at it and you commented and you are sure this is most likely a collapse, then you want to state what you are finding, that is the homogeneous opacity and significant deviation of the trachea, and then you say these features are due to lung collapse, and of course you rule out the negatives as well, and so on and so forth. So it is very important as one is writing a report to bear in mind the differentials. In this case like this, if you don't know the differentials, you can't work out the differentials. It's an image you have never seen before. You describe what you're seeing, then you say there is bilateral homogeneous opacification of the hemidiaphragms. Again, it is important for us to see whether there is air bronchogram or no air bronchogram, because in a pneumonia there will be air bronchograms. I think there may be some air bronchogram here. And of course, we also talk about the positive silhouette sign with the cardiac shadow. Okay, and then you say further investigation, the CT scan could give us more information, and so on and so forth. So in a nutshell, that's how you go about your reports. You can either mention the condition that you know, and then you can do a systematic analysis, check all aspects of the chest, just like we have listed up there. So up there we have said that you look at it systematically. Like for example, if I can just give an example here, systematically you want to say you look at the chest wall, you look at the chest wall has the soft tissues and also has the bony structures. Are there any fractures? Then you quickly look at the pleura, and then you look at the hemidiaphragm and then the mediastinum. But when you're making the report again, usually we want to start with what is most positive. Some people usually may like to start with a report which says the chest wall is normal, the hemidiaphragms are normal, but again, that may bore someone who is reading your report. But if you start with what is pathological by saying there is homogeneous opacification over the right hemithorax, which is preferentially denser in the inferior margins, then you say compensatory emphysema on the right, then you say the negatives. Otherwise, the chest wall, the hemidiaphragm, and then you conclude maybe a better way of presenting your report. So then you are able to say, yes, this is this condition, then you can usually do a CT scan. Okay, so in a nutshell, this is what we are talking about. And of course, if you want more of this, you can keep following us on our platform, on the website, on the MIG website. We usually produce these very educative videos. We've so far put on the SRT, the Spatial Radiographic Technique, in case you're interested in knowing how to do the Spatial Radiographic Technique on your own. Again, you can go there, the video is there. And of course, the video now we're going to put there, we shall put this video as well, of a quick review on an easy way to interpret these images. Excuse me. Yes, how to interpret the chest radiograph. Next, keep watching. We are going to also post a video on MSK pattern, where we shall be looking at a quick way of getting reading some of these signs on the musculoskeletal system, that is the bones and the muscles. This is what is coming next. That will be our next video. Otherwise, keep watching and keep installing in case you want anything. Incidentally, we also have teleradiology services in case you have generated some of these images and you may not be able to make a report. You have teleradiology services. We come and install our software in your system and you are able to upload some of these images and we quickly write for your reports. We will come to the end of this series. Next time I talk to you, I'll be talking to you about the MSK. I'll end here by wishing you a good festival time and bye for now.